Absolutely. So for the WIC program, there's the stores or no processors allowed to charge any kind of service fee to the WIC program.
Excellent.
And Office of Systems Integration, it's really why we partner with them for the EBT transition, because they have this long experience with Department of Social Services and their programs. But for WIC particularly, it's totally commodity-based food items. There's no fee.
Wouldn't be the point of sale at any other kind of facility.
Exactly.
Excellent. But that's just, that haunts me because it was such a, I think, snafu. Another question, we had a debate kind of in my office when we had our briefing on the agenda today about why you think utilization drops off as children age, that even though that's your largest population of eligibles, it tapers off. Particularly when you consider the new choices that you've added. My initial thought was, well, as children age out, they're no longer on formula, so they kind of drop off the WIC program. But do you have a sense of why enrollment drops off?
So we do see, we have, I think in the estimate, you'll see the pie chart that shows 57% are children. We do have another chart that breaks it down by year, and you can see the biggest drop is after the kind of that 1 year when they're not getting formula anymore. It's not a huge drop off at that point, but it's a little bit every year. And so what we think is happening is they're getting into other programs, they're going to preschool, so there's other options for them to get food benefits, but we really want the families to know that they're still qualified for WIC, and we can certainly partner with other programs to fully support that family.
Excellent. Final question for me. I had an assembly member just call me last week with an interesting inquiry, wondering whether, given some of the water safety issues that we're experiencing in some communities across the state, wondering if bottled water was covered under WIC or CalFresh. And I didn't know the answer. So is bottled water covered under WIC?
It's not under WIC, but I'd have to check with our CalFresh to see what their program is.
Excellent. Might be an issue that we have to address. You have a question, Ronnie? Somebody was shaking their head no on the CalFresh piece. Got it. All right, thank you. Excellent. So LAO?
Thank you, Madam Chair, Meredith Worden, LAO. We've reviewed these budget requests and have no concerns, and we'll certainly review any updates at the May revision.
Excellent, thank you. Finance? Public comment?
Thank you, Karen Farley with the California WIC Association. And we're in strong support of the efforts the WIC program is making to move to the EBT card. Talking about the caseload, certainly using all forms of technology is a relevant experience for young families. We will always have young families. And it's also important for the grocers, and it's also helpful for program integrity and program management and data collection. So that's something we strongly support. Secondly, the reach across with CalFresh is really important. Sometimes families don't understand they can access both programs, and that would really address, some of our concerns about social determinants of health and making sure there's good food security for the families. So we strongly encourage your support for both those issues. Thank you.
Thank you. Next witness, please.
Kelly Hardy with Children Now in strong support of these BCPs.
Thank you. Final witness.
Kathy Dressler from the Children's Partnership, also in strong support.
Thank you very much. We're going to hold this item open. Moving on to issue 2, genetic disease screening program.
Thank you. We're going to add 2 more people up here. Thank you, Chris.
Okay.
We're adding both Dr. Richard Oldney and Leslie Gaffney. I'm not sure that Dr. Oldney's been here to meet you before, but after 8 years of an active recruitment process, we finally have a division chief for our genetic disease screening program.
8 years.
8
We had to wait
years.
for you for a long time. My goodness.
We're so lucky that we were able to entice someone with Dr. Olney's credentials here. He is nationally regarded for his expertise, not only in genetic disease screening, but in congenital infections, and which is certainly on our mind right now, and other birth defects monitoring programs. He comes to us from the CDC. We just happened to find him at the right time when he thought that being in California sounded like a good idea. So I don't know if you want to add anything.
Well, I better be very nice to you so I don't run you off. Heaven forbid. Welcome.
Thank you. I'm honored to be here before you today. I am a new division chief, so for our presentation today, Leslie Gaffney is going to be presenting. She's the Assistant Deputy Director for Center for Family Health, and she was previously the Assistant Division Chief in GDSP.
Now, I want to explain that I didn't recruit him here and then take away his assistant. But Leslie was ready for a promotion, and so she just moved from genetic disease screening to become the Assistant Deputy Director.
Oh, excellent.
And so she's covering both until Dr. Olney finishes the recruitment process for his new Assistant Division Chiefs.
Gotcha.
Just wanted to make sure you knew who the new players were.
Thank you, I appreciate that.
So I'll put my GDSP hat on, and I will give you a brief overview of the genetic disease screening program and then walk you through our proposed fee increase.
Perfect.
So GDSP is mainly two programs, the prenatal screening program and the newborn screening program. Prenatal screening program is a voluntary program. We have participation of just over 70% of the pregnant women in the state. We do what's first and second trimester screening. And it's a blood test and a special ultrasound measurement of the fetus, and all of that information is provided in our fabulous computer system, which then provides a risk assessment for several different birth defects. The most notable is Down syndrome and neural tube defects. Women who have an elevated risk high enough to be considered positive are offered follow-up genetic counseling and diagnostic testing as part of the coverage of the program at no additional cost. And our second program is the newborn screening program. Newborn screening program is a mandatory program. Generally, it's a specimen that's collected from the baby's heel prior to discharge from the hospital. We are currently testing for 80 different disorders. What's of note for newborn screening is generally all the disorders for newborn screening are things that don't appear at birth. You can't really look at a baby and tell there's something wrong, and they're generally all disorders that are significant, will cause significant enough damage that if you don't identify them before symptoms appear, then damage is done, and it's usually irreversible damage. So we want to identify them from their blood test results and then put them on treatment. As I said, we're currently screening for 80 different disorders. Last year when we were here, we were talking to you about AB 1559, which requires us to add screening for adrenoleukodystrophy as soon as it's added to the federal RUSP, the Recommended Uniform Screening Panel. Secretary Burwell added ALD, adrenoleukodystrophy, on February 16th of this past year. So we are committed to screen every single baby whose specimen we received on or after February 16th for that disorder. We are planning to bring that screening live this summer, and then luckily ALD is a disorder that you don't have to pick up immediately like some of our other disorders, so we have the luxury of being able to go back and test the specimens back to February, and we will still have time to report out the results and get the kids who are positive in for follow-up. In line with that, we had spoken from as early on as the bill analysis that we would need $11 fee increase per specimen in order to put that in place. And so as part of our budget, we have an $11 fee increase. That would raise the newborn screening fee from $112.70 to $123.70. It's actually $111.70 now for the testing part, and we do charge $1 for the testing kit, the special filter paper. So passed on to patients, and usually their insurance company, and Medi-Cal is the $112.70, which with another $11 would be $123.70. We bill to the hospitals, and the hospitals in turn bill to insurance, Medi-Cal. There are very few private pay patients for this, and it's our understanding that newborn screening is part of a bundled birth package. So, any questions?
Thank you, Madam Chair. So I'm curious, would it be within this prenatal screening, do you have the capacity to screen for Zika virus, and is that happening yet in California?
Richard, I will defer to you on that. I don't think you need to do it as part of the prenatal screening program. You can just test for it, but I'll let Richard.
Yeah, CDPH is screening for Zika virus, but selectively for travelers that go to affected areas. Or there's other reasons to test them for. We don't do it routinely for everybody in the state.
I have seen in Brazil women who are pregnant being screened, and they can be told if they are carrying the Zika virus as
Yes.
part of that screening. Would it, and I show my ignorance, but if that were picked up in screening, would it change anything in the management of a pregnancy?
It would change the surveillance that's done in terms of ultrasounds of the fetus. They'd be done more frequently, and some special testing might be done during the pregnancy.
Thank you. I know there is Public Health Department monitoring for California, but I think we all want to remain vigilant. And so to the extent there's any collaboration or crossover, we'd certainly encourage it. And then, again, maybe a question born in ignorance, but are these screening protocols, these can be done at community clinics, including Planned Parenthood clinics? Do they do this type of screening?
You're talking about the Zika or the prenatal?
The more general prenatal screening.
The prenatal screening program, yes, specimens can be collected at Planned Parenthood or any prenatal care provider. They are then sent to the state program, and we actually do the laboratory testing, but they can be collected anywhere.
Right, so community clinics factor into this, including Planned Parenthood clinics.
Including Planned Parenthood, yes.
Thank you.
May I add something to that? I just wanted to say that in regards to the Zika virus, that we can, testing women is a blood test, a routine blood test. Until recently, it had to be sent to the CDC, but we're actively involved in doing that for high-risk women who've traveled and they come back. I think where our challenges are right now is that if there are infants born to women who've been exposed, is that we don't immediately know the impact of the infection. It may be apparent at birth, or it may not appear for 1 or 2 years later. In fact, the CDC is recommending follow-up for at least a year. So this is all something that we're just absorbing right now and planning for and strategizing. It's a pretty comprehensive effort that we're going to have.
But it does sound as though that detection could inform surveillance of a newborn.
Hopefully, what we're doing is we're identifying women who were exposed, tested, and determined at risk, and then we can follow up with the newborn and see what kind of services the family needs and make sure that they're integrated with that so we can anticipate ahead of time even before the birth.
Great, thank you.
Excellent. Elio, Finance. Any public comment on the genetic disease screening program? Okay, seeing none, we're going to hold that item open, and we'll move forward to issue 3, the California Personal Responsibility Education Program.
The last one is mine, because I serve both, not only as the deputy director, but as the division chief for MCH right now while we're recruiting for that.
Oh, my goodness. I hope that doesn't take you 8 years.
We've already been doing that for real. So I'm going to speak about PREP, and PREP stands for our Personal Responsibility Education Program, and this is a program that's been in place. It was passed through the Affordable Care Act in 2010, and we've been funded since 2011. So this is what we're asking for, is for approval for federal fund expenditure authority and conversion of 5 limited term positions to permanent positions so that we can continue funding. The Congress has approved continued funding for this program by nearly by acclamation, a vote of 92-8 in the Senate, which extended the personal responsibility program through this fiscal year and next. So this is essentially a continuation program and conversion of limited term positions to permanent positions.
LAO, Finance.
I'll move to approve.
Any public comment?
Hi, Kelly Hardy with Children Now and the Children's Partnership in support. Thank you.
Thank you so much. The motion has been made to approve. Call the roll, please.
Mitchell?
Aye.
Monning?
Aye.
That's out.
Thank you very much.
Final agenda item is issue 4, the Office of Health Equity. Good afternoon.
My name is Marina Castillo-Augusto, and I'm here representing Deputy Director Jamal Miller. It's been a while since I've done something like this, so my apologies if I step out of protocol.
You're the last panel today. You'll be just fine.
I'm very excited to be here to report on the California Reducing Disparities Project. Just to provide a little bit of background, before the transition of the California Reducing Disparities Project to CDPH, I had worked with a number of project leaders at the former Department of Mental Health to move this statewide initiative for underserved populations on reducing mental health disparities. Why I'm happy to be here and very proud to report out is, even though there's been a number of delays and many challenges, I feel that the department and not only the former Department of Mental Health, but CDPH has really done business differently in terms of the large stakeholder following that this project has had, and really engaging with diverse communities from 5 targeted populations to include Asian Pacific Islander, African American, Latinos, Native Americans, and the LGBTQ communities. The reason why so many delays is that we did really take a cultural competence lens in embedding many of the community feedback into sharing pre-draft solicitations, looking at departments that were called to action under this initiative, reaching across departments to ensure that we can work collaboratively to move the needle on reducing mental health disparities. This project landed in the perfect place. The Department of Public Health is a large department, and we're a small mental health component within that, but they know a lot about prevention and early intervention initiatives, which has really helped to support this effort. So recently, we announced the awarding of the statewide evaluator. The CRDP has 5 different components, the first being the statewide evaluator component, the second, a technical assistant provider, the third, pilot projects, which is really the heart of the CRDP, funding community-based organizations to provide prevention and early intervention services to underserved populations within their respective communities. And then lastly is a solicitation that is currently being drafted called Outreach, Education, and Awareness. And that's really to bridge a lot of the community effort with the effort that's happening at the county departments of mental health. This is a $6 million initiative. The funding is without regard to fiscal year. And as I mentioned, the bulk of the dollars will go to pilot projects. And this is something that, through the community vetting process, resonated with the department, that many communities have been researched, many communities have been asked time and time again what works for them, and finally, many community members see this as an initiative where we're bridging that gap. So I'd like to just pause and see if there's any questions.
Senator Monning, and I'll follow.
Thank you. Well, I appreciate the presentation, and I'm glad to see the forward progress. I know it's of critical importance to communities all through the state, but also in my district. The mention that on May 2nd, Department of Public Health announced the awards for implementation pilot projects. Is the funding already there to move forward, or is this dependent on our passage of these components of the budget?
The funding's already there. It's a matter of just moving the proposals into contracts or grants at this time.
Perfect. That answers my question.
So the original timeline for these was September 15.
Right.
So the money's been
Sitting there.
On hold.
waiting.
Good. Thank you. Thank you, Madam Chair.
Thank you, sir. Quick question. So when we say pilots, Are the pilots over the 6-year period? Is there a term for the pilots?
Sure.
And what will the evaluation look like? Because I'm most interested in how and when we'll know the impact of this investment. When will we begin to see it or feel it?
Okay, so the pilot project component is divvied into a capacity building pilot project and an implementation. We have not now announced the capacity building, so we realized in this process that there are some community-based organizations that are more sophisticated or more advanced. We also realized that there are some mom-pa, more grassroots organizations that need a lot of support infrastructurally, operations, board development piece. So we were trying to set up 2 parallel processes where we can support through our technical assistant providers to help lift some of the more grassroots mom-pa who are doing tremendous work.
That's the capacity.
That's the capacity.
Okay.
In terms of the statewide evaluation component, there are a few components that stakeholders really requested that we embed, and that's a community participatory evaluation component where community members are part of the evaluation and research from design through implementation. Now, that's pretty challenging, but in essence, we're asking our statewide evaluator, which is Loyola Marymount, under Dr. Cheryl Grill's leadership, to look at the entire CRDP project and then to also have evaluation components set up at working with the pilot projects that will be evaluating not only the number of services being provided, but if the community defined promising practices are effective or not. Some have quasi-evaluation, but some are at the initial stages of developing evaluations for each of these promising practices.
Okay. LAO, any questions or comments? So I'm looking on the question on page 68. I don't know if I missed it of the agenda. I'm clear about the $6 million for the implementation pilots. What's the anticipated total grant amount expected to be awarded for the capacity building pilots?
Let me double check 1 second. It's anticipated that for the capacity building pilot projects will be $600,000 in total funding, so approximately $40,000 for each pilot project.
Got it. Okay.
For capacity building.
Thank you. Public comment?
Hi, my name is Rocio Gonzalez with the California Pan-Ethnic Health Network, or CPEN. We want to thank the Office of Health Equity. We have worked closely with the office since its creation, as well as the California Reducing Disparities Project. We look forward to the Capacity Building Pilot Project, and we also urge the release of the California Reducing Disparities Strategic Plan. It holds a wealth of information in support of community-defined practices for reducing disparities in diverse communities. So thank you.
Thank you very much. We're going to hold this item open.
Okay. Thank you.
Thank you very much. We've got through all of our votes. Yes. We did everything. Okay. And with that, we want to thank everybody for your participation, and today's hearing stands adjourned.